I think you are familiar with this terminology of obstructive disease and restrictive disease. Obstructive is the limitation of airflow usually result from an increased resistance from partial or complete obstruction at any level, like asthma, emphysema, chronic bronchitis, bronchiectasis, cystic fibrosis, bronchiolitis. So FVC normal or reduced, FEV1 decreased, so FEV1 to FVC less than 0.7. I think you have this in lung function test, isn't it? Restrictive disease reduce expansion of the lungs. It is from outside, you know. Parenchyma is accompanied by decreased total lung capacity, like extrapulmonary severe obesity, kyphoscoliosis, and also interstitial lung disease, pneumococcosis, idiopathic pulmonary fibrosis. So proportion decrease in both total capacity, EV1 normal, and FEV1 to FVC ratio. Okay. So in obstructive lung disease, usually normal FEV1 to FVC usually 80%, mild is 70. In case the patient have usually cough, minimal dyspnea. Okay, moderate 50 to 69%. So patients usually have cough and shortness of breath and exertion and wheezing, hyperinflation, decreased entry. Severe case when this ratio is decreased to 34 to 49%. So the patient usually have cough, shortness of breath, sign of respiratory failure, and core pulmonary. In asthma, usually more than 50% is increased FEV1 after bronchodilator. Okay. This one you have it in the lung function test, isn't it? Hello? Okay.
Yes, sir.
So I'm not going to the physiology loss, but I will concentrate on the pathology part. So what is COPD? COPD usually there are two conditions linked together, which we call chronic bronchitis and emphysema. Previously, the chronic bronchitis and emphysema, they are separate disease, but now they combine together and under COPD because they found they have the same etiology is the smoking. These two conditions usually often coexist at the end of spectrum. I mean, if they started with bronchitis, they can, at the end also they manifest with the emphysema, or they started emphysema, they also get chronic bronchitis. So together they are at the end, they are coexist, both conditions. So persisting and irreversible airway obstruction, chronic progressive worsening with acute exacerbation. So what is the emphysema? Usually emphysema is morphological definition. We call permanent enlargement of the air space distal to terminal bronchiole, accompanied by destruction of their wall. Also restricted to the acinas and related to cigarette smoking. Types of emphysema, we have centri-acinar, pan-acinar, and distal acinar. So centri-acinar is usually due to the cigarette smoking, pan-acinar usually due to alpha-1 antitrypsin deficiency. Distal acinar adjacent to pleura and probably underlying many cases of spontaneous pneumothorax in young adults. So if we see here, this is the normal bronchi and alveoli, so this is normal acinar. Okay. If we see pan-acinar, so it is actually involved the respiratory bronchiole. Actually, it is started in the alveoli, and it's involved initially started in the alveolar wall and involve the respiratory bronchiole. So it takes the whole acinar, so we call pan-acinar emphysema. Central emphysema usually started in the respiratory bronchiole, and you can see the alveoli is spare, is not affected. Okay, clear? Hello?
All right,
Is it?
doctor.
Okay.
Yeah.
Okay, you can see in grass. If we see the central acinar, you can see the here. Central acinar, you can see this is the dilated air space, isn't it? And the small one is the alveoli. So it is affect the only the respiratory bronchiole, while the alveolus, they are normal. Okay, so we call central acinar. But here you can see all dilated, the respiratory bronchiole plus the alveoli. So we call this pan-acinar. They involve the entire pulmonary architecture. Okay, you can see here some area is normal, right? And while some area in the center is the affected of the respiratory bronchiole. So you can see here the usually dilated alveolar wall, okay, plus the destruction of the alveolar wall. Okay, so we call loss of the alveolar wall with emphysema demonstrated. Remaining airspace are dilated. Okay, you can see here this pan-acinar, so most of the alveolar wall are destructed and dilated. See this one, during autopsy, they open the body. Can you see the reps? This is the reps. Okay. This is the lung. This is normal lung. There is this large bolli. Can you see the large bolli? This one. This patient is die of emphysema. So you can see a lot of large bolli there. So what is the pathogenesis? Actually, pathogenesis is the tobacco smoking. Okay. So what is in the tobacco smoking? We have nicotine and reactive oxygen particles. Okay. The nicotine usually stimulates the blood cells, which is neutrophil, and the recruitment of the cells to the site of inflammation, right? If you remember the pathogenesis of inflammation, right? And also oxygen, reactive oxygen species, which is radical, release the interleukin, those also stimulate the neutrophil. As well as the free radical inactivate of anti-protease, okay, and leading to the increased neutrophil elastase. We call here functional alpha-1 antitrypsin deficiency, because we have congenital and functional. Congenital, usually there is deficiency of the alpha-1 antitrypsin, okay. Functional deficiency is due to the free radical of smoking, so it leads to the increased neutrophil elastase. This neutrophil elastase causes tissue damage, so causes tissue damage, plus also the alveolar macrophage we have. They release metal elastase and metalloprotease, so causing the destruction of the alveolar wall and also the respiratory bronchiole. فهم? Understood?
Yes, doctor.
Okay. Okay, what is the clinical features of the emphysema? Patients have usually dyspnea, is usually the first symptom, and this is insidious and steady progressive. Cough also, wheezing in patient with underlying chronic bronchitis. If you have, we said usually the two conditions are to exist, isn't it? The bronchitis, and because they have the same etiology, also the chronic smoking lead to also chronic bronchitis. So if the wheezing, that means he has also bronchitis. Weight loss is a common and severe. Decrease FEV1 to FVC ratio. Classical no bronchitis component. If there is no bronchitis, the patient usually have parallel chest, pink puffer. You know the pink puffer?
Skin become pink. The pursed lips.
Yeah, pursed lips. Actually, this one. So the patient usually sitting forward in hunched over position, attempt to squeeze the air out of the lung with each expiratory effort. We call pursed lip to maintain the terminal bronchiole. Dyspnea. Also, why the patient have dyspnea, hyperventilation are the prominent. So that's until very late the disease gas exchange is adequate and APG value is relatively normal. We said pink puffer. Why? Because there is hyperventilation actually in this case. There is hyperventilation, you know, it's not like chronic bronchitis. In chronic bronchitis, we call blue bloater, isn't it? You understand? Hello?
Yes, doctor, but can you please explain how the pursed lips will maintain the patency of the terminal bronchioles?
They try to maintain because it is open the whole time to try to get the air inside. Okay, so for the, do you know how to explain the pink butter, pink buffer?
Is it because they try to exhale out, so they purse their lips and to force the air out? Is it?
Actually, the patient with the emphysema, the primary underlying, especially those who have underlying cause, is emphysema. Okay, so I said the emphysema is due to the air distal wall, right? When there is destruction of the terminal bronchiole, okay, also include the destruction of the pulmonary capillary also at the same time, pulmonary bed, okay. So it causes decrease the ability to oxygenate the blood. So not only only is there less, because so less surface area for gas exchange because the destruction of the alveolar wall plus the capillary, so less even blood coming. There is also less vascular bed for gas exchange, so it leads to the less ventilation perfusion mismatch. Okay, and also the body then try to compensate how by ventilation. So when there is hyperventilation, there is the arterial blood gases try to maintain to the normal. Okay, understood? Because of compensatory hyperventilation, isn't it? So the APG results in this case, it's is normal, and also because of low cardiac output, the people output the afflict and disease develop, leading to the muscle wasting and weight loss. Okay.
Doctor, if the person have
in this case the patient less hypoxic, less, not so hypoxic like in the chronic bronchitis. less hypoxemia compared to the blue bladder. So we call this pink bladder, pink bladder, pink buffer.
Doctor.
Yes.
So pink puffers still have bronchitis, is it?
In this case, if there is no bronchitis.
So if the person have bronchitis, it blue bottles, right?
Yeah, in the blue bottles, the bronchitis, because there is mucus secretion, bronchospasm, so retention of the carbon dioxide. So and there is hypoxemia actually. Okay, understood. We said emphysema with pronounced bronchitis, chronic bronchitis component we call blue butter. Okay, blotter, because emphysema with bronchitis, blue blotter, we said because of the less prominent dyspnea, respiratory drive to sustain CO2, so the patient become hypoxic and often cyanotic. And also this one, in this case, the patient, if he had the primary cause is so in this case, the patient developed, pulmonary hypertension and cor pulmonale. Cor pulmonale means that patient have congestive heart failure due to the right side heart failure due to the pulmonary hypertension. Okay, in this case, we said the patient usually have bronchospasm, mucus secretion increased, so it causes the obstruction, more obstruction to the airway, and leading to the retaining of the carbon dioxide. And also in this case, the ventilation is okay, isn't it? I mean the perfusion is okay. There is no destruction of the blood vessels, but because of the return to carbon dioxide, there is compensatory vasoconstriction. So also there is mismatch of the perfusion for ventilation question mismatch also. So the pulmonary arterial vasoconstriction leading to pulmonary hypertension, and this leading to the also the patient usually hypoxemic, cyanotic, so why we call the blue blotter. Understood?
Doctor, does the pulmonary vascular spasm means the pulmonary artery vasoconstriction?
Yeah, vasoconstriction. So why the patient develop pulmonary hypertension? Okay. Usually patient death due to pulmonary failure and cor pulmonale. Cor pulmonale means the right side heart failure due to pulmonary hypertension. Okay. For chronic bronchitis, what is the definition of the chronic bronchitis? Persistent cough, productive of sputum for at least 3 months in at least 2 consecutive years in the absence of any other identifiable cause. The affect large and small airway related to cigarette smoking also. Whereas defining the features of chronic bronchitis, the mucus hypersecretion is the primary of reflection of the large bronchial involvement. The base of airway obstruction result from inflammation, fibrosis, narrowing of the bronchioles coexist with the emphysema. Okay. So in chronic bronchitis, actually there is inflammation, there is fibrosis, narrowing of the bronchiole, plus the production of the mucus. But both, I mean, it coexists with the emphysema when the disease is progressed. Okay. So how the clinical features, I mean the types of the chronic bronchitis, they say simple chronic bronchitis when there is productive cough but airflow not obstructed. Chronic mucopurulent bronchitis, there is sputum contain pus from the secondary infection. Chronic asthmatic bronchitis. This is chronic bronchitis with hyper-responsive airway and intermittent episode of the asthma. Chronic obstructive bronchitis. This is the chronic outflow obstruction as measured by pulmonary function test. Okay. So chronic bronchitis may be persistent without ventilatory dysfunction, or with progression. Chronic bronchitis may be complicated by pulmonary hypertension and cor pulmonale, also recurrent infection and leading to respiratory failure and constant respiratory. Okay, any question here? So what is the pathogenesis? As we said, the main pathogenesis is cigarette smoking. Is the single most important causative factors. Okay. Other air pollutants like sulfur dioxide, nitrogen dioxide may contribute. So what is this irritant cause? Cause inflammation. So the lymphocyte, macrophage, neutrophil, you can see is in the site of inflammation. Also mucus hypersecretion and hypertrophy of bronchial mucus gland. You can see so there is the morphology. Usually you can see oedematous, hyperemia of mucosa covered by layer of mucinous or mucopurulent secretion. Mucus gland hypertrophy, because from where the mucus come is just it came from the mucus glands, so they are hypertrophied. Also increased goblet cells, we call goblet cell hyperplasia. Squamous metaplasia because of chronic irritation, remember, lining of the epithelium. Also variable density of the inflammatory cells, we can see the mucosa, we can see the lymphocyte, macrophage. In chronic bronchiolitis, goblet cell metaplasia, inflammation, fibrosis in the wall, and smooth muscle hyperplasia. You can see here, can you see this is the glands, mucus gland hyperplasia, how hypertrophied, and also here the lining is there is squamous metaplasia, no more the columnar epithelium. Okay. You can see here a lot of dilated blood vessels here and a lot of inflammatory cells. Okay. In the bronchial wall, can you see the bronchial wall? This one. This is the mucosa. Okay, understood. So we said COPD is there are two conditions. Okay, they are finally they are exist together. So we said bronchial alveolar and bronchial injury. So in case of the leading to bronchospasm, hypersecretion, infection, reversible obstruction in bronchiole and small bronchi. But if still, I mean, injury going on and smoking, so continuing the injury leading to chronic bronchitis. So together with chronic bronchitis, if there is destruction of the alveolar wall, it leads to also emphysema together with the chronic bronchitis. Also in the emphysema, destruction of the alveolar wall, or the occasional respiratory infection, okay, emphysema with continuing injury due to because of the smoking, continue repeated infection, also leading to also the chronic bronchitis. So usually they said finally they are all together. Maybe the patient have the two conditions, chronic bronchitis plus emphysema. Okay, understood. Prior to 2004, the chronic bronchitis is clinical diagnosis as chronic bronchitis, and the cough of 3 months each into consecutive, and also emphysema pathological diagnosis as permanent enlargement of airspace, asthma also loss of function. So after that they put chronic bronchitis and emphysema together because they had the same etiology, and put it in single umbrella under COPD. Okay, any question? Faham? Easy topic.
Doctor,
Yep.
based on the histology, the last histology slide just now, most of the red is the blood vessel, right?
This one? Yeah, dilated congested blood vessel.
That indicates hyperuremia, is it? Oh, all right.
Because in chronic bronchitis, you can see hyperemia, so the blood vessels, because of the inflammation, all these cytokines released from the tobacco, also from the inflammatory cells, leading to the why there is hyperemia, because the cells is coming from the blood vessels is congested. If you remember long time the process of inflammation, remember we have dilated congested blood vessels because there is recruitment of the cells from the blood to the site of inflammation, isn't it? And also chemoattractant is by the smoking also they came. So a lot of inflammatory cells there, macrophages, chronic inflammatory cells like lymphocytes, macrophage, isn't it? And also you can see also neutrophil also. Okay. Any question? We said COPD is a common preventable and treatable disease. Is characterized by persistent airflow limitation that is usually progressive and associated with enhanced chronic inflammatory response in airway and the lung to the noxious particle of the gas. Sorry. History. How the history of COPD? Most patients of COPD usually have smoked at least 20 cigarettes per day for 20 or more years before the onset of the common symptom of cough and sputum and dyspnea, presenting commonly occur in the 5th decade of the life. I mean, if he started when he was 20 years, it appeared on the 50 year. Okay. At least 20 years, okay? So long term of smoking and also heavy smoking. A productive cough or an acute chest illness is a common, okay? The cough usually is worsened in the morning and produce a small amount of colorless sputum. Breathlessness is the most significant symptom, but it usually doesn't occur until the 6th decade of the life. By the time the forced expiratory volume in 1 second (FEV1) has fallen to 30% of predicted, the patient is usually breathless after minimal exertion. So wheezing may occur in some patients, particularly during exertion and exacerbation, with disease progression interval between the acute exacerbation becomes shorter. Cyanosis and right heart failure may occur. Anorexia and weight loss also develop and suggest a worse prognosis. Understood the history? Actually started with the long term of smoking and also started with cough. Then after that it progressed to the breathlessness and wheezing sometimes if there is exertion. Not like asthma. Asthma usually patients have wheezing, isn't it? So in physical examination, or physical, you can see here the physical signs specific are quite specific and sensitive for severe disease. Patients in severe disease have tachypnea and respiratory distress. Okay, so usually you can see the patient using the accessory muscle. Okay, and also you can see also have cyanosis and elevated jugular venous pulse. Why there is jugular venous pulse elevated? Due to what?
Right heart failure.
Yeah, because of right heart failure. This is in severe case. Okay, and peripheral edema are observed. This is in severe or complicated COPD, where they develop cor pulmonale. Okay, measurement usually by forced expiratory time if EV maneuver is assembled beside this one in the for lung function test. Thoracic examination reveal hyperinflation, barrel chest, wheezing. We can see diffuse, decreased breath sound, hyperresonance because of air trap on percussion and prolonged expiratory. Also, you can hear coarse crackles beginning with inspiration and hair and wheezing. Okay, this is the physical examination. So, what is the principle of management at the COPD? Usually, the first thing to stop smoking cessation. Okay. And usually when we said, according to the, we said what happened in the COPD, they have bronchial smooth muscle contraction, right? And also bronchial mucosal congestion and airway inflammation and increase. If we know the principle, we can give the appropriate treatment. For bronchial smooth muscle contraction, so we give bronchodilator. For bronchial mucosal congestion, we said there is a congestion, isn't it, and edema, and we give steroid to decrease the inflammation because steroid is inflammatory. It's important to give, the steroid beside the bronchodilator. Airway inflammation infection, we give because with the bronchitis and emphysema, the patient usually have the infection, so we give antibiotic, and also for mucus we give mucolytic. Understood the principle of management? I mean, if we know the pathology, how it's happened, what is going on in the chronic bronchitis and emphysema, we can give the appropriate treatment for that. Okay. So in case of, severe, we can give autotherapy, oxygen, nutritional support, sometimes surgical, giant. In case of giant bulla, we give bollectomy. We can do lung volume reduction surgery, also lung transplantation in severe case. Okay, this is for just for smoking. So the second topic is the bronchitis. Do you want to continue or you want rest?
I think
we can just proceed. Yeah.
Proceed.
Rest.
Continue.
Well, continue. Okay. Okay, what is bronchiectasis? This is the definition. Permanent, abnormal dilatation of bronchi and bronchiole caused by destruction of the muscle and elastic support tissue. Result from associated with chronic necrotizing infection. Okay. In emphysema, don't mix with emphysema. Emphysema, we said terminal bronchiole, isn't it? Distal alveolar. But this one is dilatation of bronchi and bronchiole. Okay. And due to this one is due to what? Due to repeated infection. Really, the bronchiectasis is due to the other disease, you know. What is the clinical presentation is cough, fever, coitus, false smell, purulent sputum, dyspnea, and cyanosis. You know, coitus, full smelling means a lot of, sputum. Sometimes they can cough with the half of the cup sputum, and it is purulent, usually yellowish or to green color, you know, because of the infection actually. Okay, you can see here the bronchiectasis. Can you see those? The dilatation of the bronchi and bronchiole here. This one. Okay. So, what is the predisposing condition? We have the bronchial obstruction due to tumor or foreign body or mucus impact, congenital, maybe hereditary condition like cystic fibrosis, immune deficiency state, immotile cilia, Cartigener syndrome. So it is cilia, you know, it is very important for removal of the foreign body. So if there is immotile cilia, that's mean any infection can be trapped and persistent infection. Necrotizing pneumonia, Staph aureus and Klebsiella and TB also. The main pathogens we said chronic obstruction and the chronic persistent infection. Okay, these two processes are critical, and in the pathogenesis, I mean there is two. Yeah, should be obstruction plus chronic persistent infection to cause the bronchiectasis. Also, bronchiectasis is not a primary disease, we said, but it is secondary to other cause. We said either, remember the previous slide? Sorry, this one, we said it is maybe due to tumor from body or mucus infection or due to other disease, congenital or necrotizing pneumonia. Okay. We said the diagnosis is depend on the history along with radiological demonstrate of bronchial dilatation. Okay. Usually, what is the morphology? Dilated airway maybe become cystic. Active chronic inflammation, desquamation of the epithelium, squamous metaplasia, fibrosis, and scarring. What is the complication? Hemorrhage, lung abscess, respiratory failure, core pulmonary also, septic emboli because of the infection, secondary amyloidosis because of chronic inflammation. You can see here, can you see this? The dilatation of the bronchi and bronchiole. And they usually are filled with the mucus. Okay. Okay, see here, this is the bronchi. You see, you cannot see even the mucosal layer because of destruction of the necrotizing inflammation. Can you see this inflammation? You cannot see the wall very clearly because due to inflammation already destruct the wall of the bronchi. Okay. Any question? Hello? Understood? Hello?
Doctor.
Understood?
Doctor.
Do
yeah? We classify bronchiectasis under restrictive or obstructive?
Obstructive.
Obstructive.
Yep.
Okay.
So, okay, I will give you just for how to differentiate between asthma and COPD. Asthma, you have the NPPL, isn't it? Usually, in asthma, the onset usually in the child or adolescent, but in COPD, mid-40 and history of smoking usually. Okay. The trigger here in the asthma is usually allergy and exercise, and in COPD is usually respiratory tract infection. Okay, and also the smoking. Reversibility, the asthma, usually there is a free symptom between the exacerbation, between the attack. But here in this one, in COPD, partially reversible with smoking cessation and bronchodilator. Sometimes, I mean, if it can be reversible if the patient stop smoking and also have bronchodilator, but if there is no scarring, in the bronchial wall, I mean, is not in severe case. Treatment both same things, bronchodilator with corticosteroid. But also in asthma, we need also to dilate the bronchial wall and also to release the inflammation. The COPD and also comparison between COPD and asthma. Onset in midlife, symptoms slowly, long. Wait, 1 minute. Hello. We said COPD, the onset in midlife, but in asthma, we said in childhood. Symptom is slowly progressive in the COPD. Here in the asthma, symptom vary from day to day. Okay, this is it should be in COPD the long-term history of smoking. But in the asthma, the symptom usually worse at night and morning, and also the trigger, we said the allergy, rhinitis, eczema present. Also, there is family history of the asthma. Okay, I mean you have to know how to differentiate between asthma and COPD. I mean both have wheezing, bronchospasm, and the same. But there is a difference when we said this is asthmatic person or COPD. COPD usually occur in the onset in the mid life, but in asthma usually there is a history in childhood of asthma. Okay. So we said here. Usually we said the emphysema and chronic bronchitis all together, they are together. Okay, is due to, we said emphysema is alveolar wall destruction, here productive cough with air emission. So this, and asthma is another category because it is reversible obstruction and due to bronchial hyper-responsive by triggered by allergen and infection. And the allergen, it can when there is a patient exposed to the allergen is lead to the APG cells. Remember the antigen presenting cells to T helper, then T helper will switch the cell to IgE, then they bind to the mast cell. Okay, when there is second exposure to the allergen, so the mast cell will degranulate it and release of the histamine. Histamine causes the obstruction, and other mediators like arachidonic acid or always can causes leukotrienes, also causes bronchospasm, as well as other mediator causes inflammation. So this is, I mean, the etiology is different from those two groups of the COPD. This one is due to smoking. Okay. So this is the three category. I mean the comparison. We said in chronic bronchitis, the anatomical site is bronchus, and usually there is mucus gland hyperplasia and hypersecretion, and the etiology, as we said, tobacco, and sign and symptom is the cough sputum production. In bronchitis, the main site is bronchus, and it's due to airway dilatation and scarring. Etiology usually persistent or severe infection. Here is also have cough, purulent sputum, and fever. Asthma, also the main site is the bronchus, due to smooth muscle hyperplasia, excess mucus, inflammation, and the etiology is the immunological or identical causes, and usually have episode of wheezing, cough, and dyspnea. Emphysema, we said sinus, is due to airspace enlargement, wall destruction. The trigger or etiology is tobacco smoking, as in chronic bronchitis. Also have the dyspnea. Patient, if he have cough and sputum, that means he already have two existent condition, both bronchitis and emphysema. But most of the emphysema usually have only dyspnea. Bronchiolitis, the bronchial inflammation, scarring, and also tobacco smoking, pollutant, and cough, also dyspnea. So this is in summary to comparison between the obstructive airway condition. Okay, any question?
Doctor, can you show again the dilatation of bronchi and bronchioles in bronchiectasis in the gross picture?
Okay. See this one? Can you see the dilatation? This is the bronchial wall. Can you see the dilatation of bronchi? Both. This is the dilatation there. See, the alveoli is normal, but the problem here is the bronchiole. The bronchus is dilated because of destruction persist. And can you see that inside the bronchi there is mucus there? Purulent mucus. Okay. Okay, faham?
So why is there scarring in bronchiectasis again?
Because of the persistent infection.
Okay.
Persistent infection, inflammation, and then lead to scarring. Okay.
Okay,
Any
doctor.
question? Any question? I think we have finished. We have finished. Is there any question?
Doctor, can we have the slides?
Yeah, okay. You don't have the slides from last year?
Yeah, we have from last year, but some of the asthma, the pictures cannot load.
Oh, okay. Okay. Okay, any question? How do you do in the, is there any news for the exam?
I think if the CMCO is extended, the exam will be online, Doctor.
What about the CBS?
I think based on what John said, it will be carried out during our holiday.
Oh, after hemato, you mean?
Yeah, after hemato.
I see. But if extended, that means you will carry on the RESP as online exam, isn't it?
Yeah.
Oh, you are happy with the online exam, is it?
No.
I hate the online exam. Okay. Okay, all the best.